Sanjay is 53-year-old engineer with diabetes history of 6 months back. When he came for a routine checkup, he complained of weakness. His family history was positive for hypertension and myocardial infarction. He was smoker for 30 years, but he quit that 3 years back and now trying to lead a healthier life. He had a myocardial infarction 3 years back. His current weight is 92 kg, height is 5 feet 8 inches, and BMI is 30.7. Blood pressure 140 by 90 millimeter of mercury. His HbA1c is 8.4%. Lipids, LDL cholesterol is 137 milligram per dl, that is slightly high for diabetes. SGLT is 37, that is low, and serum triglycerides are 156 milligram, that is also high. So here we can see a higher HbA1c, which is target is 7.7 percentage. Now it is 8.4 in this case. Renal functions are eGFR 65 ml per minute. Urine albumin creatinine ratio is 50 milligram per gram, which is moderately increased. Drug history, metformin 1 gram twice daily is taking. He is also taking telmisartan 40 milligram for hypertension and atorvastatin 10 milligram for dyslipidemia. And he is also on aspirin clopidogrel. So what should be the patient-centric approach for the management of diabetes in this patient? So as we know that the treatment of diabetes should focus on protection of microvascular complication and macrovascular complication, which includes CV protection and weight reduction. In addition, we should also reach glycemic goal with no or minimal hypoglycemic events. And we should give him a convenient dosing schedules of drugs. So the primary consideration in any diabetic case should be cardio protection and optimizing glycemic control for CV risk reduction. So by adding SGLT2 inhibitors and DPP-4 inhibitor combination, benefits received are basically cardio-renal protection, simple regime, early durable achievement of glycemic goal, weight loss, and the most important, less hypoglycemia. So cardiovascular disease is a leading cause of morbidity and mortality in adults with type 2 diabetes. It not only starts early, 12 to 15 years early in people of diabetes, but there is also almost twice risk of developing these complications than normal population in diabetic patients. Framingham Offspring study, which included around 2,000 patients, suggested 2/3 of the patients of diabetes have subclinical cardiovascular disease, and diabetes increases subclinical CVD by almost 4-fold. In addition, the vascular wall in patients with diabetes is well known to have advanced atherosclerosis. EMPA hearts, that is effect of empagliflozin on cardiac structure, function, and circulating biomarker in patients with type 2 diabetes. In patients with type 2 diabetes showed that empagliflozin resulted in early and significant reduction in left ventricular mass circulation, as detected by cardiac magnetic resonance imaging, and also suggested that it also reversed the cardiac remodeling, and it is possibly a main contributor for cardiovascular protectivity effect of SGLT2 inhibitors. This was also shown in clinical trial. One of the most famous clinical trial is EMPA-REG outcome study in 2015. This study demonstrated that empagliflozin reduces the CV events by 38%, and it also reduces all adverse cardiovascular events in type 2 diabetes and improves, give benefit in CV disease. All type of CV deaths were reduced with empagliflozin. More prominent absolute benefit were observed for heart failure related death and sudden death. Post hoc analysis of EMPA-REG demonstrated that consistent CV mortality benefit irrespective of prior CV events, MI or stroke, heart failure burden, CKD, and baseline HbA1c. Mechanism proposed for CV effect of SGLT2 inhibitors include osmotic diuresis, natriuresis, lead to blood pressure lowering, decrease arterial stiffness, vascular resistance, and decrease weight, decrease uric acid and oxidative stress. It has also been reported that SGLT2 inhibitors promotes reverse cardiac remodeling, improves myocardial energetics and filling conditions, and reduce LV wall stress that leads to blood pressure reduction and improvement in arterial stiffness. EMPA-HEART CardioLink 6 study demonstrated that empagliflozin could produce early reverse cardiac remodeling. In addition to this, there is a very good data with linagliptin. We have Carmelina and Carolina trials. They demonstrated CV and renal safety of linagliptin versus placebo in type 2 diabetes. So EMPA-LINA is available as first in-class treatment of combination of SGLT2 inhibitors and DPP-4 inhibitors. At week 24, this combination showed significant HbA1c reduction of almost 1 to 1.5, which was addition to metformin, and HbA1c decrement by EMPA-LINA has demonstrated 1.81% HbA1c reduction compared to at 24 weeks. So the combination offers a suitable strategy to achieve the target of HbA1c without causing hypoglycemia and weight gain. These are the two major challenges in patients of long-term diabetes and those who have cardiovascular events. With availability of these drugs, now SGLT2 inhibitors are becoming the first choice to treat any type 2 diabetes with increased CV risk or heart failure or any history of fast heart attack or stroke. So in this group of patients with high CV risk or renal disease or heart failure, we should use EMPA combination, and linagliptin addition in that will provide additional HbA1c control and cardiovascular protection.